Before he starts, I should tell you that, there was much part of the procedure could not be recorded by cine to be shown because the patient became breathless in between and we were all in a hurry. Yeah.
So, good evening, everyone. I hope I'm audible and my
Yeah,
slides
you
are visible.
are audible. Please continue.
Yes, I'm Dr. Raghuram. I'm pursuing Interventional Nephrology Fellowship under Bala Sir, Tirunelveli. Today, uh, I'm going to discuss an interesting case. So, coming to the clinical presentation of the patient, a 56 years male with ESRD initiated on hemodialysis in January 2026 to a right temporary catheter, then exchanged with a TCC. And he had underwent a left BCF fistula creation in February 2026 in outside hospital. And he came to our center on 19th March with absent thrill in the fistula site for the past 15 days. So it was a 6 weeks old fistula, which had sudden fistula dysfunction 15 days before he came to ours. So
We didn't know whether it was functioning from the beginning because
yes.
it was his version. Yeah. Yeah.
Yes. So we have proceeded with a AV fistula Doppler, which showed this anastomotic site and there's a juxta-anastomotic thrombus. And at about approximately 2 inches from the anastomotic site, there was complete absence of the cephalic vein. There's no discriminable lumen beyond the site. And there's no patent vein or thrombus. Nothing could be visualized. So at this point of time, we had a critical question whether to do angioplasty. Is it truly worth attempting the angioplasty in this case? Even Balasar had an opinion that there will not be much clinical uh, uh, result for this patient. But we have proceeded because of, in view of academic purpose, we have proceeded with the case. So we have done an angiogram through the radial artery using a 6 French sheath, which revealed we can barely see the cephalic vein and with a minimal trickle of flow there. So we have introduced a 035 thermo wire and we have successfully crossed the anastomosis, but we could not, the wire could not be negotiated above the level. So we have introduced a 5 French guide wire for support. Even the guide wire could not be negotiated above this level. And we have done a contrast study at this level, which showed complete absence of vein. So then we had to introduce 014 PTCA guide wire supported by 2 mm non-compliant cardiac balloon. Eventually, after which it allowed us to pass through the lesion. So the thermo wire has passed successfully, crossed the cephalic arch, and we have placed it in the IVC. But the problem is we do not know the extent of the lesion. This contrast injection could not delineate the vessels in the mid-arm and the proximal arm. So what we had to do is, we had taken a retrograde approach using a 8 French sheath through the femoral vein. And we have passed the guide wire and it crossed the cephalic arch. But we can see the coiling of the guide wire in at around the shoulder area in the proximal 1/3 of the arm. So with this, we are able to at least guess the lesion, the proximal end and the distal end of the lesion. And this shows a good anterograde flow in the central veins. So we have successfully positioned the balloon in the distal end of the lesion. And we have used 4 into 40 mm Mustang PTA balloon dilatation catheter. And we have successfully done angioplasty from proximal to distal end. And we can see the wasting caused by the tight lesion here. But during this procedure, patient had sudden breathlessness, which necessitated us to quit the angioplasty procedure.
You
So the
went up to six French now.
Yes, sir. So the plasty was done serially with a 4 mm and then 6 mm Mustang PTA balloon dilatation catheters. And the post-plasty, we can see the good flow in the fistula cephalic vein. And since the patient was breathless, we cannot assess the central veins properly, but the post-plasty video can it shows a good patent central veins. And post-procedure, the patient had good thrill and Doppler showed good flow in the vessels. So this is a challenging long segment venous occlusion, which was successfully recanalized using a dual approach strategy, resulting in the recanalization of functional flow. And these are the highlights. The early failure of the BCF. We did not know exact duration from which the fistula inadequacy is there. And the Doppler which suggested complete cutoff of in the vessel and difficulty in crossing the lesion. Then considering a dual approach which helped to define the anatomy. And so even the complete venous cutoff with no clearly visualized extent of the lesion can be successfully salvaged. This is about the case. I sincerely thank Dr. Bala sir for giving me this opportunity to speak in the informed meeting. Thank you so much, sir. I would like to have some questions or suggestions from seniors.
Yeah, this is not so much for the big deal about this case. But the only thing is, before taking up, we thought we would never be able to do, because absolutely by ultrasound, we could not see any collagen or thrombus beyond 1.5 inch from the anastomosis, which was filling up, but no thrill. It was a distended vein up to 1.5 inch from the anastomosis. And there was no continuity of the vein, which could be made out by Doppler. So we thought, and we didn't know whether post creation, how good was the flow in the arm, whether there was, the problem started right then. So this was never a maturing vein which got blocked. This is what I guess. But we managed, although there wasn't any dye passing through even after putting in the guide wire. The only thing is we could not take good pictures because the study had to be, I mean, the procedure had to be abandoned. But now he's back with good flow and now, good thrill. And we are not punctured yet now because as far as I am concerned, this is not a matured fistula yet because this was made patent only now. So that was my intention. So never say no, even if you think it may not be possible. That was the thing. So, any comments from others? And
Why do you think he had breathlessness?
like he was not on, dialysis
Okay, poorly dilated.
because, yeah. So, not because of the procedure, because this went on for quite a long time in the cath lab, and he had. he had no other access. There was fever on the right side thing, and it had to be removed. So we thought if something good happens here, we'll start dialysis, within a few hours or the next day. But we had to rush him and put in a temporary access and start dialysis.
That's one of the reason for doing this procedure also, sir. Not only for academic purpose. Actually, the patient had a failed RC also, and a couple of CRBSA from the current perm CAD. So we had to salvage this access for the future dialysis purpose. So that's also one of the reason for doing this.
I
So I
think
think
the
Dr. Manjunath has also joined. Dr. Manjunath, any comments, please?
Thank you, sir. Just wanted to know what happened to that. There was a anastomotic thrombus also. It looked like it was slightly extending into the artery, sir.
Uh,
Sir, there was
see that.
hardly. I don't think there is any thrombus in the
So,
juxtamus too,
yeah,
sir.
actually, the proximal part of the vein was quite big in size with some pulsation, no thrill. So it was, you see the thrombus was towards the end of the patent vein, not in the anastomosis or in the juxtaanastomosis. It was 1 inch or 1.5 inch beyond. So that was maybe it was getting thrombus was getting started to create, and another few days maybe the whole segment would have clotted.
Okay. Got it.
I think important point that we learned
And
from this case is, sir, important point that you've actually taught us today is the fact of calculated persistence. So here we have a case which on table has actually shown that there was absolutely no flow beyond. So generally what we would do is just abandon this kind of a patient. And but you have gone ahead and done a retrograde, gone all the way around, and then you've been able to move and manipulate the catheter, the guide wire, all through using a different technology. And then after that, we've been able to get to a point in which we made an intervention possible. So I would say this is an example of a calculated move. Though I know there was a lot of skepticism before you started this procedure, and obviously when you did the procedure, you must have said that, why did we do it? Because the patient suddenly went into a state in which he went into congestive heart failure, or so
Yes.
that was, I think that was just because you just kind of revascularize the push, the place. So maybe that's the reason why the CHF took place in a patient who was never dialyzed before.
Maybe.
Any questions from anyone? Any comments, please?
There is one comment from Dr. Deepak Selvanathan. He says, for arterial cannulation, do you give any cocktail injection, and what is the sheath out protocol? So do you just do a compression, or do you just do a TR band application?
And this arterial cannulation was from the radial artery, right, Karthik? Yeah,
It's a radial artery.
yeah. Retrograde through the vein was not possible because vein was not discernible. So, and many times we have done arm issues going through the many people wouldn't approve. We do that way because we are able to start dialysis immediately if you could recanalize, in the very next day we start dialysis in the arm without puncturing putting in the sheath in the arm. But in this case, no, we could have put in a sheath in the vein in the arm. So it was radial puncture, and it was 6 sheath we used because there was a cephalic. Then you put in a bigger balloon, so we put a 6 pin sheath, and that removing that sheath is not a big issue at all. We don't do any other manipulation to arrest the bleed. So it was not a brachial artery puncture. I don't know what. Yeah.
Just compression, I think that's what everybody
Yeah,
does. And
just compression, sir.
Actually,
Yeah.
Vinod, we had, Karthik had left the right femoral vein without removing because if there was problem, we could go again through the femoral vein the next day.
Yeah,
The ideal
exactly.
artery was removed because we didn't want to have it longer. But next day we found that it was all working well and the Doppler showed good patency till the cephalic vein. So then we removed the femoral and sent him home.
No, one of the reason we chose retrograde also was
Right.
we were suspecting some lesion in central veins also. So we need a larger sheath, and we were suspecting some lesion in cephalic arch because the guide wire didn't pass through post the cephalic arch also. So
It went up to the upper arm
upper arm, yeah, exactly.
from
So
above.
so that's another
then
very important teaching point that you've actually told the viewers here, is not to remove the femoral sheath.
exactly,
That's
yes.
the standard thing that we've also been practicing here, that when we have a difficult access that we've recanalized, we want to keep the sheath there for some time, or maybe the femoral access for some time for later on.
Correct. Yes.
So I don't see any more questions coming here. There's a last question. Would you put the patient on any anticoagulation or any antiplatelets?
Yes,
Uh,
antiplatelets, but not on anticoagulation, actually, without any stent.
because we didn't see any obvious much thrombus load anywhere. So routine aspirin deplat, loading dosage and uh, Plavix later,
Yeah.
Yeah, so these are protocols, I think,
3 days.
which will
His
differ from
heparin will
different
be there
centers.
also.
I think different centers will have different opinions on the
Mm.
use of antiplatelets and anticoagulation. For example, I think what we do is we anticoagulate
But
these
what do you do,
patients.
Vinod? Actually, uh, with
So we use heparin, sir, for the first
anticoagulate.
three. Yes, we use heparin for the first 3 days, and then after that, we generally don't
Mm.
use any antiplatelets after that.
Oh. See, in cases where we have, if we had to use one of those uh, thrombolytic agents, sometimes in the thrombus load is there, we use small quantities of alteplase to disintegrate the thrombus along with the balloon. Those cases we continue anticoagulation for longer period of
Yes, sir, that's right.
time. Right. So I managed two meetings.
Sir, there is one more question, I
I didn't
think.
want to miss this meeting.
Yes, thank you for coming and joining us. There's an interventional cardiologist here who says he has a very difficult time getting venous accesses. And what are the key points for successful entry into the venous end?
Venus in the where?
I mean,
So,
I think
yeah.
fistula cannulations, I guess.
So this is while doing a fistuloplasty,
Yeah, you see, mm.
getting
Yes,
venous
Vinod.
access.
Actually, my early attempts. Actually, I started doing this only after reform. I think I told this in many forums. I was doing renal artery and creative fistulas, but not AVF fistuloplasties. So my first attempts through the partially thrombosed or diseased uh, outflow vein. Maybe I was clumsy, but most of them, I spoiled this minimal flow also. So once I started doing the radial artery, things improved better, and I'm persisting with that. Although there is a group of interventionists who don't approve arterial entry, but I think in our group, quite a few of us are as first choice go through the artery.
Yes, I would agree on that. That the artery is a better choice as compared to, because this concern is very well addressed by the intervention cardiologist here. So I don't think we have any more questions, sir, over here. Vineet, could you
Yeah.
please?
Okay.
If there
Okay.
are no further questions, I would like to thank once again Dr. Kambhar sir and hope that the device is actually in clinical use in the market soon. Also, I would like to thank Dr. Raghu, Dr. Karthik and Dr. Bala for the interesting case. And with this, we would come to the end of today's session. Thank you very much and have a good night.
Thank you. Thank you.
Thank you.
Thank you. Good night.